Today, the main area is the upper anterior left side, but for a bonus treatment, I will place first the lower left side. Lower left side first, I will try one implant, and then the main area, upper left anterior side. Please, Y incision, like this manner. This Y incision is very helpful for the lingual flap elevation. And then motor number 9, the sharp end. And then the lingual flap, full thickness elevation. Well, crestal dimension relatively good, but I don't want to GBR. So crestal reduction first. Usually crestal reduction for the minimization of the GBR. Of course, before the crestal reduction, we have to evaluate the available bone to the inferior nerve. Okay, it's good. So this is the, I will try the SQ implant 5.0, 8 millimeter. First drill, my favorite drill from the SQ implant. This is the point cut drill function and the side cut drill function. Today, I don't want to use the guide surgery. You keep the disangulation, 5 millimeter here. Okay, this is the initial drilling. By the drill extension, 8 millimeter. First drill, 2.2. Usually left side, extension is necessary, not interfere the adjacent tooth. If you collect this bone, please keep this one here. During the drilling, sometime this drill captured the autogenous bone. It's a very good autogenous bone. So this bone, I will use the upper anterior area. Next drill, 3.5. Lower jaw, implant apex, a little bit buccal torque is better. Buccal torque. And then 4.0. So you can keep this angulation. You can keep this autogenous bone for a G. And then final drill, 5.0. Okay, let's check the bone cortex perforation or not. At this time, same manner. Your left finger holding here, and then you insert this one. So this manner, you can check the lingual cortex perforation or not. Okay, definitely no perforation. And then buccal side is okay. Okay, this is the finish the drilling. Okay, next one, implant placement. This is the 5.0, 8 millimeter SQ implant. Please believe, 8 millimeter implant. And then deep placement is a key point. Deep placement, RPM. Initial stability is very good. About 90% by the engine driven. And then 10% by the torque wrench. According to the premolar angulation, I will maintain the disangulation. From the marginal bone, 1 or 2 millimeter deeper will be better for the maintenance. Okay, I feel about the 30 Newton initial stability. Let's check the depth. As you can see, this is the lingual wall, 1 millimeter or 2 millimeter deeper. That means no GBR is okay, no GBR. Okay, let's check one more angulation. Okay, it's good. Because this first premolar, second premolar angulation is a little bit different. At that time, bisecting angulation is okay. That means this is the, after crestal flattening, worldwide terminal deplacement means no GBR is okay. This, the SK implant, the drill coordination is very excellent. So you can just follow the implant drilling sequence one by one. Definitely require healing cap. And then this healing cap area, one more tightening by the torque wrench because I don't want to loosening during the tongue force or foot force. Okay, I finished the lower left side. Okay, suture. Okay, I finish lower left side. Okay, I wanna, this area, I think maybe about 2 implant will be better instead of the 3 implant. And then this the premolar area, sinus residual bone about the 6 millimeter. So I will try the Crestal approach rather than lateral window. Crestal approach and this area. Okay, first one, flap design. This is the aesthetic area. So don't touch the papilla. This is the limited flap. First one, mid-crestal incision. Please feel the bone area. This is the non-aesthetic area, so you can touch, cutting the papilla is okay. And then vertical incision. This is the non-aesthetic, so you can cutting the papilla is okay. Non-aesthetic area. But this anterior area, papilla preservation incision, there are so many names of this incision. Papilla preservation incision, limited flap, Gomez-Roman flap, H incision. There are too many names that are available. Okay. Okay, flap elevation. First step, touch is the incision, and then second one is drilling. Please always remind, this is the much granulation and the fibrous tissue, and then palatal flap. Palatal flap require, this is the insertion, and then lever action here. Lever action, with this manner. Okay, this is the palatal wall, margin. We have to expose the clear margin of the palatal bone. Please expose the buccal wall, definitely, margin. And then remove the granular tissue. Whole soft tissue component should be removed before the drilling, so we have to expose the sound bone first. Okay, palatal bone. Well, one. I think the 2 implant is better. 2 implant. So first one, the Crestal approach. There are 6 techniques are available for the Crestal approach. So this time I will try just like a quad technique, this one. The Dentis implant first drill is about 7 millimeter. This is the enlarge the hole first. Enlarge. And then increase the hole about the 3.5. This is the SQ 3.5 drill. And then 4.0 diameter drill. And then I will try the Crestal approach technique. At this time, the first drill is the 3.8. And then this is the 5 millimeter stopper. It's very similar, 5 millimeter. I will change 6 millimeter stopper. And the next one, the core elevation. This is the special kit. This is the hollowing drill, not conventional osteotomy. So this is special designed the core elevator here. Very light force here, light force. So that means after core making, just take out with this manner. 톡톡톡톡 치는 느낌. Okay, just this the core capture the osteotomy here. My purpose is very simple. I don't want bone grafting in the sinus area, Crestal approach. So this core insertion, very small. And then this core elevated by the self-threading implant placement. So the second implant, SQ 4.5, 8 millimeter implant. Implant to RPM. Okay, initial stability is good. So at this time, I place. I think the immediate loading, not possible because the paralleling pin from the SQ implant, I try here, and I already keep the disangulation, this implant area. Okay, first drill in the lateral incisor, I keep this angulation here. Okay, second one. Sometimes sinus nasal flow is not clear. So that means require you check here. Okay, not penetration of the nasal floor. So I want to keep this angulation here. Okay, next drill, 3.5. Final drill, 4.0. If I place 3 implant, it's very difficult to make a 3 inter-implant distance. So this area, 2 implant is better. 2 implant. Okay, final implant today, 3 implant. Okay, 4.0, 10 millimeter. Depth controlled by the torque wrench. So this requires healing care first. After surgery, we will take an impression for the immediate denture. Please open the membrane. Usually I apply the membrane first before the bone grafting. And then please check the flap elevation, flap mobility. And then we try the tissue approximation for the GBR. This is the tissue approximation. So at this time, a little bit increase the volume. So it requires some tangent releasing here. So make a space. And then number 12 blade, 15 blade. Tangent releasing. So deep side here. Okay, I want to check the flap mobility. Okay, it's good. Okay, please wait. Okay, this is the Dentis collagen membrane. So we measure this will be better. Deep side here, right? So at this time, first one, most apex area which apply the bone tag here, and then the healing cap area, it require some the cutting, please. This is the nasal mucosa. So at this time, maybe our bone tag fixation here. This is the bone tag here. Resorbable membrane bone tag is very, very important here. Okay, I'm holding here because this area maybe bone is very soft bone. Sometimes bone tag engagement is very difficult, but you have to try to find a good bone area. One bone tag is necessary, one bone tag for the resorbable membrane stabilization. This is the big impact of non-resorbable membrane GBR. If we apply the cover screw by the PTFE membrane, not proper at this time. So this kind of membrane fixation first by the bone tag, and then apply here with this manner. More GBR here. Increase the packing, the inferiorly packing. I think that this is sufficient. Okay. And then grossly covering here. So I think that this white cutting will be better. As you can see, bone tag fixation first is very important for the GBR stabilization. So at this time, so I covering here with this manner, and then reinsertion to the plater side. In this manner, so insertion to the lingual side, plater side. Okay, next one. This bone particle just slightly packing to the inferior side, and then you try this one here. I already applied the tension releasing. At this time, I think the first suture is the vertical matrix will be better. Vertical matrix starting from the buccal side. Okay, almost done. I think that this case not proper for the immediate loading. So this is the 5 millimeter. And then palatal flap 5 millimeter. And then re-entering from the 1 millimeter superiorly. This is the vertical matrix for the second layer, and then this come out, this area. This is the abolting vertical matrix, abolting. So the reason, because the secondary intentional healing is very predictable. Okay, just one by one, simple interrupt suture. Now, the vertical incision area. At this time, the anterior area is more important, anterior side. Always feel the good direction, and one area not position, and reverse turn, and 2 more, totally 5 turn. At this time, this area starting from the palatal side here, open wide. Okay, the posterior vertical incision, I will try. One more silk, please. Today, final suture. And then after surgery, this patient moving to another chair and then take an impression for the immediate denture. Very good patient. Okay, let's check. Saline.